Welcome to the Inside the Boards podcast, the podcast dedicated to helping you learn to think like a question writer so you can study smarter, not harder, and succeed in medical school. And now here's your host, Patrick Beeman.
Thanks again to Panacea Financial for supporting our health system science series. Here again with the inimitable Dr. Ned Palmer, MedPeds physician and Panacea Financial's chief strategy officer, to discuss today's question, which is, what's going on with student loan debt?
Student loan debt, especially medical student loan debt, is high and getting higher. This year, the AAMC's report on student debt was published, reporting that the median graduate from medical school with student debt has $200,000 on the day of graduation. That's up anywhere from 3 to 4% every single year it's risen over the last decade.
I mean, I'm in the Midwest, but $200,000 is a lot of money. It's like pretty much almost what my house costs, and I have a pretty big house.
And those are Midwestern dollars in real estate, which go pretty far compared to...
Correct. But still, you could live, in the Midwest in a pretty decently sized house for the cost of med school debt. And then, God, how much of that's going to be like just straight up interest over the repayment terms? My wife has a crap ton of debt. It's well over 300 at this point. And I remember looking at it right after she got done with med school. And then like 4 years later, when she was a resident and just making the minimum payments. And it's like, wait a minute, what? How is it more and more and what? So it's crazy, but yeah, it's definitely a worry. So how is Panacea helping with this issue? You guys just forgiving all students' debt, or able to do that yet? Or
yeah, it's a program we're pretty proud of, having $1.6 trillion worth of cash injection into the economy. What your wife experienced was not at all unique. That $200,000 that we talk about every year does not take into consideration that when you finish, you go into a training program where you're underpaid for anywhere from the next 3 to 7 years. You're not making full interest payments on that loan, so you're still underwater. For my own personal situation, I graduated with $290,000 in student debt, and it rose to $380 by the time I had finished my residency. Now that I'm done with 2 more years of fellowship and just now getting to pay it off, it's at $412,000 before this year's COVID freeze.
You guys should put like Ned's student loan debt as a little counter on your website, so people in real time see it either go up or you pay it off.
I actually like that if it didn't hurt me so emotionally.
Right. Yeah. But sorry, I laugh, but that's a soul crushing amount of debt. I was military, so I don't have that issue, but my heart goes out to you.
And you've seen it through your wife. You're still living it because she bought a house, but instead of getting a house, she got a diploma.
Right, exactly.
So the state of student debt is bad and getting worse. And frankly, as sad as it makes me, none of the policies put forward seem like they would be targeted towards medical students or medical education or even graduate education. $10,000 forgiven, even $50,000 forgiven, as sad as it makes me feel, is not enough and is woefully inadequate to target the state of student debt. What Panacea Financial is working on is what we want is to get people out of high interest student loans into much lower student loans through refinancing at much earlier stages so they don't gather money so quickly and continue to drown you for the rest of their career.
Like how early?
Well, the first decision that's most important is to find out if your projected career is going to qualify for public service loan forgiveness. It's the most important financial decision of somebody who has student loans. And that has to be the first question asked. If you're looking at a career where you're likely not eligible for public service loan forgiveness because you're working in a for-profit hospital, you're not working for the state or local or tribal governments, or you're not planning on working full time for a nonprofit and you don't qualify, you really ought to be looking at refinancing as soon as you are assured that you're not going to be eligible for a forgiveness program.
Gotcha. So when do most people make that choice, though? Because this is pretty foreign to me.
Most people make that choice towards the end of residency, when they've
last like second 2 years, last 1 to 2 years,
when they're really looking
securing a job.
Exactly. When they're really looking at the career, what comes next, where they want to live geographically, really planning and making those next steps. So it's really towards the end of residency that this starts to come up. And then once that future plan's in place, that's the best time to really start exploring your options and seeing if refinancing your student loans is right for you.
We've said before in these little conversations, these mini talks we've had, that reminding medical students that they are adults, but hopefully this doesn't sound patronizing to the listeners, but since many of you are basically subsisting on student loans for your rent, utilities, all the expenses of your life, the term even like refinance might not have a lot of practical meaning, even if you could pick it out as its definition on a multiple choice test or write one out. But like practically, what does that mean? What are we talking? Like, should I even be listening? Should I skip forward on this little segment? What in practical terms would refinancing a student loan have on a person's life, potentially?
So I think refinancing is a great topic to bring up, not just because I'm interested. I'll admit my own biases here, but I think it's important. One of the most important things for starting as early as medical school is to start educating yourself about the financial landscape. There are a lot of actors out there that don't necessarily have your best interests in mind. And without education, you're liable to be taken advantage of when all you really want to do is work, cure people, do good, and practice medicine. So refinancing, just in its most simplest form, is taking a loan from one organization and renegotiating the terms of that loan. So you can change the interest rate, you can change the term that you're paying off the loan, you can change who's holding on to the loan, so the servicer. And with a student loan refinancing, what you're looking to do is take it out of where most medical students get their loans from the federal government, taking out of the public sector and refinancing it within the private sector.
So hence you mentioning it's important to know whether or not you're going to be eligible for public service loan forgiveness, because obviously you don't really want to go through the process in refinancing like it is with buying a home or something. There is some upfront cost to a refinance of a student loan. Is that true? Not the case?
So it is not the case at Panacea Financial. I can't speak to all of our rivals and competitors out there, but at Panacea Financial, there is no cost to refinance the student loan. There's no application fee. There's no origination fee. There's no prepayment penalties. Is really just a straightforward renegotiation, effectively, where you get to set your new interest rate and your new term and your new payments with a new organization.
Okay, so how do they look into doing that then?
Well, I'd invite people to go to panaceafinancial.com/ITB and you can take a look.
Oh, thanks.
Right from there, we've got loads of resources on student loans. We have one of our advisory board members, Dr. Josh Daly. He is published in the Journal of Graduate Medical Education and Clinical Pediatrics, all about what kind of science or best practices exist for medical education loans. And so he's a pediatric cardiologist out of Arkansas. He was trained in Cincinnati. He's absolutely brilliant. And this has been his passion and his academic research. And he's helped us draft and craft our articles and decision-making tools for anybody to come in and use to learn more about student loans, the landscape, and what they can do with them to maintain financial health.
Got it. So do you guys then just refinance loans, or are you able to provide loans. I mean, I know you guys do like the PRN loans for the fourth year students or residents, early career physicians, right, who need a little extra cash at a fair rate. But what about your third year medical students and I don't know, you need more money to cover living expenses and the subsidized federal loans don't cover it?
This is not uncommon in expensive cities. Federal loan disbursements tend to be capped, and there may be some small adjustments for cost of living, but there's a really big difference between Ohio and New York.
Right.
And so we totally understand that. Panacea Financial does not provide loans to pay for tuition. What we have, exactly like Patrick mentioned, are PRN loans, which can help offset some of your costs for short-term expenses. But if you're really in dire straits in a very expensive community and the public loans that you're getting aren't enough, that would be something that you want to readdress with the financial aid officer at the school and see what options exist for you.
Gotcha. Well, I would think a lot of our listeners, I mean, some of them are probably studying for step 1 or step 2 who are coming from out of the schools out of the country or programs out of the country. But for those of you who are U.S. grads and aren't exactly sure what your career path is going to be, probably the best place to start is to get in now with Panacea Financial and open a checking or savings account, start building a relationship with them, and then later on at least explore the refinance option, see if it makes sense. I'm going to keep saying that on these segments and throughout the series because, yes, thank you, Ned, for you guys and supporting this, supporting Inside the Boards and medical education. But at the same time, I want our community and us to support you guys because what you're doing is cool. It's like your slogan is banking for doctors by doctors. You have a bunch of doctors in the an advisory board of physicians, and at least 2 of you on the co-founding team are actual physicians, correct?
Practicing in med peds.
There you go. So like Ned said, panaceafinancial.com/ITB. And then always we have to include Panacea Financial, a division of Sona Bank, member FDIC. Welcome to the Inside the Boards podcast. I am Patrick Beeman, your host. This is our Health Systems Science series. Today we are discussing healthcare economics and policy with our guest, Kate Kim, who's a second-year medical student at Rutgers and faculty member and associate dean for continuing medical education, pharmacist, physician, and former I don't know what your title would be, but you were very involved in the pharmaceutical and biotech industries prior to your current academic role, Dr. Paul Weber. Just to provide an overview of what we're going to kind of try to cover in today's episode is just quick to look at the USMLE content outline. Just a reminder, guys, this is stuff you have to know. This is not afterthought stuff. It's the third pillar of medical education. And these are the things within medical education that really sets us as physicians apart from pure science. So what are we talking about today? We're going to touch on areas of healthcare policy and economics, things that in the USMLE content outline are listed as access to care issues, social justice, types of insurance, navigating the insurance system, reimbursement issues affecting safety and quality, emergency services, pay for performance, lots of things related to policy could be said, but the goal is to communicate something to you today that you can take with you to the exam center on test day. Big thanks to you both for joining us today. We'll start with Kate, though. You're a second-year medical student, but there's probably more to you as a person than that. So you want to give us a little bit of your bio and maybe the thing professionally or personally you're most proud of accomplishing thus far in your life?
Sure. Well, thank you so much for having us on today. Yeah, sure. So I can talk a little bit about my journey to how I got here and just about some of my experiences prior to coming to medical school. So I went to undergrad down in Washington, D.C. at Georgetown University. And I think it's really where I kind of got interested in health policy in the first place.
Were you at the Center for Clinical Bioethics at all?
I was not affiliated with that department, but yes, I know that Georgetown has a great bioethics department as a whole. So during my junior year, I actually interned on Capitol Hill at the House of Representatives under one of the congressmen of New Jersey. And it was really then that I became more interested in the policy aspect of things. And I think just being in college in our nation's capital, it really was contagious, that energy, that political climate that really drew the students and just the population to really just care about things larger than oneself. That was my first taste of working in the policy space. It was 2017, I believe. So there were a lot of big changes going on in healthcare at that time, too. It was right around the American Health Care Act that was being debated. And so it was a really fast-moving time to be on the Hill. And when I was in college, I guess I was still kind of unsure about whether I wanted to pursue a degree in medicine, a career in medicine. So I was really exploring all of these different areas in healthcare before really choosing to apply. And after my internship on the Hill, I decided, because I still wasn't completely sure whether I wanted to go to medical school, I decided I wanted to gain a little bit more experience in this space. So I spent a gap year, or the first year after graduation, working in healthcare consulting in the DC area. And I was in the federal health and human services sector. So our main client was CMS. We'll actually be talking about this a little more in the cases later, but the project I was working on was a bundled payment evaluation project, kind of examining the efficacies of the models that they laid out recently. And it was there that I learned a lot about just like how much of an impact and real kind of changes that can come from policy and how that affects physicians as a whole too.
Yeah, and I'd say it's probably like a black box to a lot of us. Like healthcare policy seems nebulous at best, I would say, unless, from my perspective, maybe the rest of the medical students out there don't feel that way, but I certainly do.
Yeah, no, definitely. For me as well, too. And I was so grateful to have had that opportunity to it was really a learning experience for me being out there in the workforce and, gaining all that firsthand experience. And it really kind of taught me more about the workings of, what it means to be in healthcare policy. Yeah. So then I guess from that experience, I decided to stop trying to, separate this whole idea of, I'm really interested in policy and still my desire to want to practice medicine. By then I'd gotten a lot more clinical experience too as well. And so both of these things really interested me. And so I thought to myself, why do these things have to be separate per se? So I still wanted to be a doctor and, work with patients and stuff, but I really thought that I could still somehow pursue that field of policy as well. And I guess I thought that was also really important for doctors to have when we are treating our patients and when we are navigating the systems of healthcare as well. So that was kind of my background prior to coming to medical school, and really the catalyst for developing this non-credit elective with my classmate Sonia Ball and Dr. Weber.
Yeah, and I'll definitely want to expand on that because we'll get into that. But Dr. Weber, your background, tell us a little bit about yourself.
Sure, thank you, Patrick. I'll add, like Kate, that I was influenced positively as a medical student because my training was during the height, early days, but the emergence of the AIDS epidemic. And during that time, there are many parallels that I've seen that really match with the current COVID pandemic. Particularly at the time, there was not initially a medicine that was available to treat HIV. But more importantly, there was just a lack of information, a lack of knowledge, and a lot of misunderstanding. So that led me to a tremendous passion to want to make a positive difference in the world for my patients, for my community, and especially in a broader sense. So I made a commitment. I actually wrote something down in a diary that I wanted to do something special in HIV/AIDS. And that was a journey now that's been for well over 30 years of really a lifetime of service. And along the way, one of my mentors told me, this was back about over a dozen years ago, that I should look into health policy as a career in an area and really put that together with my experience as a physician and as a pharmacist. And that stuck with me from that phone call on a car ride home. And since then, which was in the summer of 2009, I began to do teaching myself. I met colleagues who were trained in the area. And I also then transitioned into oncology. So my intersection was, how do you improve awareness, basically about these new medicines that were emerging in cancer? How do you help the public understand where they fit in? And also there emerged access issues, because we were bringing medicines that were starting to really change the boundaries and especially improve the standards of care in cancer. But also they were becoming increasingly more expensive. So that's where policy really helped, and a combination of advocacy, which is bringing a voice to individuals who did not either have the time, maybe not the financial wherewithal, and certainly were dealing with a lot of stress. So having the voice for both patients, professional organizations, and others was something I began to gain interest. And as I came to Rutgers, it gave me a great opportunity then to see what was possible, especially working with talented and exceptionally dedicated students like Kate and her colleague Sonia when we put this course together. To learn of the students' interest in health policy was very heartwarming to me, because it's something I wanted to do. Once again, you heard Kate's perspective, but I also wanted to combine. I didn't see this as two separate paths, but I felt that the physicians now, and especially as we train our future physicians, those like Kate, that we provide them to be as best equipped as possible for the medicine of tomorrow, not only the medicine that's coming up. And that's why, as you know, as you've also referenced, Patrick, the AMA's Health System Science Initiative, and really having that as a third pillar of undergraduate medical education, is where this all fits. So essentially everything has come together. And it's been, from my perspective, a multi-decade, but it's been very exciting to see. It remains a wide open and uncharted path, but it is also, to me, a great representation of how you can get individuals together who may not have previously worked together and really develop a common good. And that's what I see coming out of health policy, and especially even now we're seeing examples of this with COVID. That's good to hear.
And at this point, I probably would want to talk more specifically about this course, this elective year you've both referenced, because the way we had set up this series was to take a look at the publications that Elsevier had put together with the AMA related to health system science, and look at kind of like key elements that are covered in that book. And so we put together a plan for 6 discussions. One was generally what is health system science, and then today we've got the economics, policy, healthcare delivery kind of aspects, and there's 4 others. But with each one, the AMA found us individuals who have some practical experience or deliverables, if you will, related to the area that we're discussing. So healthcare delivery, economics, and policy, it's one of the chapters in the Health System Science Review book. How does your work in this elective you're referring to kind of bear on that? Now, I'll ask Kate to kind of explore that more to start.
Yeah, sure. So as I briefly discussed earlier, so this whole thing kind of came to fruition because just like through a combination of a lot of teamwork. So my classmate Sonia and I both had a really strong shared interest of pursuing more education in the health policy field during our time at Robert Wood Johnson. And so we had the idea to create a non-credit elective to fit in the framework of the health systems curriculum at our school. And so we approached Dr. Weber, who we knew had substantial experience in this field, and we thought he would make the perfect faculty mentor to kick things off. And then right around this time is when COVID really hit hard. So then we, completely had to adapt because we had planned initially for this elective to take the form of lunch lectures with speakers and students in attendance live and such. And so we thought about ways of adapting this to a virtual format. And in addition, so the full name of our elective is the Healthcare Policy and Emergency Preparedness elective. So that is where the emergency preparedness aspect also came in, because we wanted to integrate just the different responses to the COVID-19 pandemic and how to best equip ourselves to handle these kinds of emergencies moving forward. Our curriculum really tries to cover a lot of different areas of healthcare policy. So this could take the form of health insurance and reimbursement, advocacy in the legislative process, role of social media in healthcare, et cetera. And something that I really love about our elective, and that's really special to me, is that not only do we hear from field experts as our lecturers, but we really try to incorporate that peer-to-peer learning as well. So far, this is our first year of the elective, but so far we have had student speakers for our virtual events. And that, I think, was a really great opportunity for us to learn from one another. And I know for me personally, especially during my first year, it was always so great to just hear different backgrounds from my fellow students and just learn from the older students as well, who have kind of gone through similar experiences as we have. And it was really inspiring. So that's something that I really feel is special about our elective as well.
Yeah, and I looked at the syllabus, and it mentions some things that I just even as titles, I'm thinking, man, I wish I had more of this in med school. But you talk about, introducing students to the fundamentals of healthcare policy, health insurance and reimbursement, for instance. And I think that's so critical to me now, as an attending. I spent 7 years in the military, never had to worry about billing, coding, things of those nature that are day-to-day part of my life now. And so I remember when I started working in the hospital as a laborist, thinking like, I really don't know what any of this stuff means, E&M codes, just reading this. And so the thing I've come to say is, like if I work at Taco Bell, I understand how I'm paid. And that is how many, tacos or chalupas or, whatever Taco Bell is selling now. However many of those are sold, that's kind of where my money, and compensation comes from. As a physician, there's so many different ways to be paid. I learned even more when my wife was negotiating her first job out of residency. So many different ways or pots of money from which salaries are drawn. And to me, that sort of follow the money can reveal a lot about institutional values, institutional efficacy, how organizations are run, what their commitments are. And my kind of response to how do doctors get paid, healthcare economics in general is shrug my shoulders. I don't really know, and it's nice to have people be able to speak to how my premium as a patient that I pay for insurance each month eventually translate into compensating my doctor and keeping the lights on at the office where they work and paying the support staff. It's just crazy to me how complex this is. And that's just a small slice of what we could be talking about today here, and not even the biggest focus. But I don't even know where I was going with that, but I just really like saying that tacos example, to be totally frank, because I think it makes a lot of sense. But but to move on to some actionable or questions that we can really dive into. So fundamentals of healthcare policy mentioned here in this syllabus. I mean, what are the fundamentals of healthcare policy?
I think if you're going to look at fundamentals, you really start with the value equation, and that is, you don't necessarily have to be a math expert, but if you just picture the letter V as one side of the equation, an equal sign, and then on the numerator a Q, for quality and basically also outcomes. And then the denominator is C for cost. And I also would add a multiplier to that equation of the patient experience. So the left side of the equation is value, and then the right has the outcome over cost times a multiplier of what the patient experiences. So when we think about it, if you really boil it down, if we have a great experience with something, it has more value. And for us in healthcare, if the patient experience can be improved or is excellent, that also from the patient's perspective is of higher value. If we can also then improve their outcomes, how they are able to live each day and perhaps do what they wish to do and do that to a greater degree, we've improved the outcome. And along the way, if we're able to reduce the cost, we lower the denominator, that increases the value. So that's to me, that's a starting point. And when we go back, and another fundamental part of this is the legislation, now the law, of the Patient Protection and Affordable Care Act, also known as the ACA, which has been law for over 10 years. It was actually became law in March of 2010. And that has really, spawned so many of the components of how we've seen different components of healthcare emerge. Kate mentioned earlier her work with CMS on a consulting basis, but the Innovation Center and some of the models, including bundled payments, which we'll talk about in one of the cases, that was a direct result of that legislation from the ACA. So we have these fundamental springboards that have now amazingly over a decade that have led us to what I see as an increased interest and an increased importance for healthcare professionals, particularly physicians, to better understand and have certainly at a minimum an increased awareness of how this fits, knowing both the world around you as well as the at the same time making sure we stay absolutely true to our one-on-one conversations with patients. And always the most important part of what we do in the moment is being fully focused on the patient that we're seeing at the time.
Absolutely. Kate, in helping put this elective together, did you consider what were, in your judgment or even objectively measurable gaps in students' undergraduate medical education related to healthcare policy and related matters? Like, how did you decide what would need to be included as useful in approaching these things and teaching them or learning them?
Yeah, so I guess one big theme that we try to highlight throughout our elective that we think is particularly important for medical students who are going to be future physicians is the concept of advocacy. So we learn all of this, these useful kind of tidbits of information. We have all of these knowledge sources that are given to us, but really how to utilize that to make actionable change, I think, is really important. So that's how we decided on our self-directed learning component of our elective. So we ask each of the participants to write an essay, which can be a form of a letter to a local elected official, really advocating for an issue that they believe is important for them. So that's something that I think is going to be really useful for the students anytime in their career as well. And as far as what you were saying specifically about any gaps in our knowledge, so another aspect of this elective that I think is, important to its development is that because we are new and because this was our kickoff year, we're really valuing feedback and input from the students that are participating in the elective. So right from the very start with our kickoff lecture, we encourage students to submit feedback and any topic areas in which they wanted to see more lecture topics from us in the future, so we could reach out to the appropriate experts or lecturers to have that in the future. So a lot of what our spring semester series is going to entail is directly derived from the students themselves.
Well, in that case, do you want to get into more of what you might learn in an elective like this by taking on some of these cases?
Yes, let's start. But again, I would mention, Patrick, that the whole goal of the course is to bring this to life. Health policy can seem very nebulous.
Yeah.
You listed a whole number of subjects, and we didn't even have time to list a whole chapter in it.
Right.
But what struck me was looking at student feedback, and it said to me, not only just teach us the topics, but really bring it to life. And that's what I think is so important. And by having this forum for the students, it's a living, breathing course. It's going to be fresh. It's going to change semester to semester, not even year to year. And that certainly will be, we'll pay very close attention to current events.
Yeah.
But that's the exciting part of it, is having the students feel ownership, leadership, and again, that they can take away and say, you know what, I want to learn more about this subject. I heard a great speaker. I want to know more, and really pull out their curiosity and their inquisitiveness and let them take it further. So to inspire them.
Yeah. All right. So our first case, Kate, why don't you go ahead and read this STEM, and then we'll dive into the different aspects of healthcare policy that this draws out. And just disclaimer, for some of these cases, yes, thank you to Elsevier for letting us use this content. But some of these are not quite in USMLE compliant structure. But nevertheless, we're confident that you'll take away something that you can apply to your test taking and in the future, your career itself. So, all right, let's do it.
Okay, so this case, for decades, Treble Healthcare, a statewide system comprised of 15 hospitals and 22 community clinics, has relied on fee-for-service reimbursement models. Amy Jacobs, CEO of Treble, has completed her annual performance review with the board of directors. Over the last year, Treble's main competitor, Clough Hospital Corporation, has moved to an entirely value-based model. And now Amy faces pressure from the board to do the same to keep up with the ever-changing marketplace. During next fiscal year, Amy will ask her team to develop bundled payments. Which of the following is not an objective of value-based healthcare? A, cost containment. B, generating volume. C, creating more access. Or D, improving patient outcomes.
Well, we can break this down and look at the STEM and, kind of pull out various terms or pertinent positives, negatives, and then discuss what the correct answer is, or we can give the correct answer now. I'd kind of leave it, since you're the faculty here, Dr. Weber, to tell us what the best pedagogy is for those who are listening and probably brushing their teeth or driving along trying to learn a little bit about this stuff.
Yeah, I'll upfront provide the answer, but I want to be able to give everyone the background behind it. So our answer is B, generating volume. That's what's not an objective of value-based healthcare. And let me explain why. What I like to tell my students is they should be able to derive answers or information and not simply memorize it. So let me help you with the background. The fee-for-service model, which has been around for some time, is set up so that providers are paid for the services that are performed. And so what's resulted is that providers wind up ordering more tests, performing more procedures, and managing more patients in order to be paid more. That's generating volume. You do more, you generate more income. But what happens here is that you still have costs that are determined by what the commercial payers will pay in the private market. Then there's a certain percentage of what Medicare would pay for these services. But really overall, it's that these different services, the different component parts are separate. Each little piece becomes a particular service. Thus, the other term is that it's unbundled. It's all by itself. Each piece is by itself. They're not all put together. So thus, each service is paid for separately, and then providers are paid for retrospectively for the services they deliver based on their charges or annual fee schedule.
So you're saying if I do a hysteroscopy in the hospital, and I'm, of course, using equipment the hospital bought, I've got the anesthesia people there, I've got a scrub nurse, I've got, perhaps an assistant, we've got supplies, we've got my knowledge and, expertise required license to perform the procedure. So you've got all these little things make up one payment, if you will.
Well, actually, it's each piece gets its separate payment.
Okay.
So let's say you as the doctor in charge would receive your fee. Then there may be a fee to either an outpatient center or hospital for the room itself. And then the services, let's say, if you need to have an anesthesiologist or other team members. So every component part gets a separate fee. And that's what happens.
But there's a different way to do it.
Yeah, so there's a multiplier effect. And we'll show you actually, when we talk about the bundle payments, how this now gets put together. So what everyone should take away here is in that fee for service, each piece winds up getting charged or paid for separately, and everything keeps generating. So you have a multiplier effect.
Got it.
So the inflection point about the ACA, or Affordable Care Act, what was coming out of this was value-based care. So we talked about the value equation, V equals Q over C, as the basis. And so the effort here was, how do we, most importantly, try to improve our outcomes? And then concurrently, can we reduce healthcare costs? And that's what led to value-based care off of this model, improving value, improving quality and outcomes, and also decreasing cost. So what value-based healthcare does is it ties payments for care delivery to the quality of care provided, as we mentioned. But one of these models is a bundled payment model. And what happens is an insurer looks and says, as an example, you can do this procedure, let's say a knee surgery. And instead of each individual who's part of it and each, again, as I mentioned, the hospital room, let's say, or outpatient center room and different charges, everyone, it's all put together and say from going rates, we know that if you perform this procedure and do it according to evidence-based guidelines, it should cost a certain amount. So basically you get a total amount up front, but you get from there, you're not able to really get any more money on it unless there's some extraordinary circumstance. So they figure out what everything it is and they put it all together, if you will, in a bundle, and that's what a bundled payment is, combining everything. So what we want you also to appreciate further is maybe, again, this next question, which is, what are the component parts of bundle payments, to further explain it to the audience. So first we talked about value-based care. Now we're going to take the different types of models that arose out of the generation of value-based care. 3 of them are accountable care organizations, bundle payments, and patient-centered medical homes, but our focus will again be on bundle payments. So I'm going to read, or actually ask Kate to read the next question, which goes into about bundle payments, and I'll provide further explanation about what characterizes bundle payments.
Sure. So the next question asks, when designed appropriately, bundled payments should include which of the following components? A single payment that covers all the care required to treat a patient's medical condition. B, being contingent on achieving good condition-specific outcomes. C, a price that provides a fair margin for delivering effective and efficient care. D, built-in parameters for responsibility for unrelated care. Or E, all of the above.
All right. I suspect that the audience probably has this one, that it's all the above. As we mentioned earlier about a single payment, we talked about outcomes, developing a price that, again, is reflective of everyone's effort. And the other, D, I'll talk more about this, about if something happens, let's say this patient who just had knee surgery, where I am now in the Northeast, we just had a storm and there's a lot of ice around, and let's say they wind up in a car accident and wind up needing another knee surgery. Well, that's an unrelated event. Who pays for that? Well, if you're in the bundle payment, really it should be that you build in your parameters about who that essentially you don't have to pay for this whole new second surgery, which is again unrelated to the original one. So when you look into the details about what are 5 main characteristics for bundled payments, the first item is that there is a single payment that covers all the care required to treat a patient's medical conditions. We put everything together. The second is that it's contingent on achieving a good condition-specific outcomes. In some cases, there's even care guarantees. But this is, as mentioned earlier, if you follow evidence-based practices and guidelines, you should generally wind up with good condition-specific outcomes. The third part is that you cover a defined patient group based on its complexity. So if you have patients, let's say, are at a higher risk, you again provide appropriate payment to account for that, maybe some extra care that would be needed. The fourth is about the having specified limits of responsibility for unrelated care, issues that arise that no one expected, and certainly not related to the particular episode or the particular care that's rendered under this payment. And also, there are actually provisions put in to mitigate against any outliers or catastrophic events. So this helps. Again, if you're going to ask physicians and groups to take on risk, they need to have some level of protection as well. So that's where you have limits of responsibility. So that's one of the choices about built-in parameters. And finally, a price that provides a fair margin for delivering effective and efficient care. Most importantly, we want our patients to do well. We want them to be able to return or to gain the lives that they hope to have. We want to make that possible. So those are the 5 characteristics, and that's what led to bundled payments. How basically, once again, a single payment for services provided for an entire episode of care.
So with that being said, you mentioned as part of the bundled payments, ideally you have the specified limits of responsibility for unrelated care. A good example, I think, would be that knee surgery and then a completely different knee injury related to a slip and fall. That might get just a different bundled payment, correct?
Then you would look at that as a whole nother, what's called episode of care, a whole nother instance in which you need to do care once again. But what you're doing in a bundled payment is saying, for this next step of care that the patient needs, we'll give you all the money to account for what should usually be done according to the guidelines and evidence and best practices.
Now, if a patient gets osteomyelitis following that knee surgery and requires 12 weeks of infused antibiotics and another a couple surgeries and things like that, how do bundled payments handle something of that nature? Is that where you have this risk adjustment in criterion 3 you mentioned?
And that gets back also to the 4th point about specified limits of responsibility. So certainly there are situations that do arise, but if it's shown that the team did everything it possibly could in terms of following the proper procedures, and again, following evidence-based medicine and guidelines, then they would have this level of protection, which you would be within those limits of responsibility.
That makes sense too. It also seems, it seems better or more good in terms of the ethics of it is my inclination to consider it that way, removing that incentivization that the more venal among us are probably, subject to overblowing, overdoing procedures, things of that nature. So is that part of the idea that bring this in line with the ethics of our profession and commitment to patients? Because it can't just be economics.
I don't see them as certainly being separated. First and foremost, all of us take an oath.
Right.
Let's begin with the Hippocratic Oath when you're at the white coat ceremony, and certainly whether that's, and I know there's, the students this year, many of them, probably most, if not all, had a virtual white coat ceremony, but whether in whatever format it is, when you first take the oath in the beginning of your journey to when you graduate and once again take the oath, and really, the ethics, I also say your character and your judgment all come into play. And we want certainly everyone to be compensated fairly, but most importantly, we want to be able to do the best that we can, unencumbered by or feeling torn, if you will, to have to make a choice between economics and ethics. Instead, ethics should really be the fabric. We're conducting our profession because we are in a trusted profession, and in addition to have a medical license, where society is granting us responsibilities as well. So we're responsible to society, certainly, of course, to our patients, families, populations, and communities. Ethics, to me, again, is the constant fabric and thread in which and within everything that we do.
Yeah, you sound like Ed Pellegrino, who I was his at the Center for Clinical Bioethics at Georgetown, one of his fellows in 2007. Just inspiring individual. Try to name drop him all the time because absolutely everyone should read some Edmund Pellegrino. But
yes, and I had read some of his work just a couple of months ago in a different course that I teach in. We have an ethics. We actually have a 3-part ethics component to it. So
That's another conversation, but one I would like to have. All right, let's move on. Back to policy itself, policy proper, because you can't separate really anything in medicine from the ethics. But
so the next case, and I'll have Kate read again the stem and the question is again, to me, really exemplifies, reading through the question, but really us today boiling down what are your key takeaways? What are the health policy principles and concepts that we want you to be able to remember and carry with you your whole career?
Ben, an airplane mechanic for MT Airlines, was injured on the tarmac during a routine engine safety check. He went to the company's health clinic for evaluation. During his intake, he provided important information to the doctor, but it was quickly decided that he had to go to the emergency department for treatment. The clinic does not have an electronic health record and did not bill his employee health plan. Still, Ben remains concerned that his information at the clinic could be shared with his boss. In this scenario, which of the following is protected under the HIPAA privacy rule? A, a patient's name, address, birth date, and social security number. B, payment or billing information related to an individual's health. C, a patient's physical or mental health condition. D, all of the above. Or E, none of the above.
Right. So I will go again to my point about deriving rather than memorizing, because this particular case has a few key and very important fundamental components to it. So let's begin with, of course, providing the answer. So the answer here is a patient's physical or mental condition. And I know the audience immediately is going to wonder, well, why not some of the other choices? Well, first, when you think about it, regardless of whether it's HIPAA or other types of settings, it is our responsibility to hold, when patients trust us with their most personal information, that's where we have to be very mindful of when and how we share it. So in this case, you would not share a patient's physical or mental health condition to an individual superior, their supervisor. Now, but going further, what this particular case is really asking the audience to do is to recall the concept of protected health information, which again is something very critical to understanding HIPAA regulations or protections. So I'm going to read a statement to everyone, which is that protected health information, or you may hear it as PHI, is any information about the health status, provision of healthcare, or payment for healthcare that is created or collected by a covered entity. Now, it's a different language, but let me take a pause here. What's a covered entity? It can be basically like a physician's office or a hospital where your primary effort is related to healthcare, or a business associate, so someone who helps you with it. But the key thing is, what are protected health information? And there's many different, there are about actually 18 of them listed if you go to the website for Health and Human Services. But if we look at this, let's go back to the case. Here you have the patient works for an airline. So the primary business is airline, is transportation, but they have an employee clinic. So a unit of the airline is one that provides care. So what the other key point here is that the clinic does not have an electronic health record and does not bill the employee health plan. And what that brings in is does it meet the condition of what's called a hybrid covered entity? So again, I would ask the audience, after listening to this, take a look at the definition of hybrid covered entity. But basically what we're talking about is, in order for the HIPAA privacy rules to apply, the entity not only needs to be providing care, but it also should be able to, or it should have, be involved with exchange of electronic health information electronically, and also will bill a health plan. But in this case, the clinic does not have an electronic health record and does not bill the employee health plan. So it doesn't fully meet the definition of a hybrid entity, and thus it would be actually excluded from HIPAA protections. That's why I emphasized in the beginning of this discussion that choice A, where you have the patient's name, address, birth date, and social security number, that can be found in other information. And since this clinic is not, as defined, a covered entity under HIPAA, that's not protected information, meaning that it still could be linked back to the patient and, of course, not be covered. The second, about payment or billing, the issue here is that the clinic doesn't bill. So once again, this information is not going to be protected under HIPAA's privacy rule because it's not the clinic does not meet the definition of a hybrid entity. But so therefore, it's certainly not all of the above, and it's not none of the above because, as mentioned, a patient's physical or mental condition is not information that should be provided to an individual supervisor. Certainly, this is where we know that if we need to have an absence, we have to get a doctor's note. And that's why. And I myself, having been a line manager or being a supervisor, it was never my place to ask exactly what happened to the patient. But as long as they provided me with a document or a letter from a doctor, then their absence, of course, was excused. But the key here is to let's take this case actually now and make it a part two. If this clinic actually did have electronic records and build the employee health plan, all we're actually doing is taking the two knots out of this case, then it would be hybrid covered entity, which means once again that there is a health unit that provides care within a business that overall its predominant business is not related to healthcare. So airline as a transportation, yes, some of the airlines are now carrying the vaccines, but that's not their number one priority, if you will, or their number one part of their business. It's to transport. But rendering and providing care is not what they're doing, except they offer an employee health clinic. And if the clinic did bill...
sorry to interject, but to be clear here, Ben, our patient in this scenario, is concerned about his information being shared with his employer. Are you saying that as written, where the airline does not have an electronic health record and does not bill the insurance that Ben has, that his information can be shared with the employer under HIPAA, or outside of HIPAA?
Yeah, well, what can be shared is his name, certainly his address, his birth date, social security number, because that also would be available in the employment records.
Okay.
Again, billing information really gets into some more non-specific details. But what cannot be shared, and that's why it remains the correct answer here, and as written, is what's the specificity about his health, his physical or mental health condition. In this case, it's not described, but he had probably, who knows what, he was injured. So,
right.
But the details of that cannot be disclosed to his boss. So it's different between the company and a supervisor. The direct supervisor should not know specific details about your health in order to maintain a certain distance and avoid, issues, let's say, whether the person has that come up eventually in their year-end review and so on. So this question, again, is a little tricky, and that's why I go back to saying, what are we really trying to, what's really trying to be teased out, or what's trying to be emphasized with this case? It's one, to go and look at what is protected health information. Again, what is the HIPAA privacy rule? Why is it set up? Again, to protect us so that our health information is not widely disseminated, and certainly not, and if it is, it's done within the proper boundaries and rules. Again, knowing that if a person sees a health professional for a health-related condition, that the details of that condition are not disclosed because that's what they're trusting us, right? They're trusting us with they're trusting us with their innermost secrets. Finally, the other thing, and Kate, if you would just scroll a little bit, is a particular definition, which I mentioned earlier, about a hybrid entity. So mainly you think about HIPAA from let's say a freestanding physician office or a health system. But in this case, you have a business which happens to have an employee health clinic, right? So this that's what I hope that everyone takes away here, is just knowing what the definition of a hybrid entity is under HIPAA. And also, please be sure to look at what protected health information is. Those are the key things that you want to do, because it's not just for a board exam, but it really is something that you will want to know and need to know for your whole career, is what information can we pass along and when and to whom. Absolutely.
Super important. And most of the organizations for which you'll work or intern or research are going to have annual or some recurring HIPAA education in
Right.
I mean, I think a lot of us have a sense of, oh, this is one of these computer-based trainings that I can hover my mouse over the arrow and click as fast as I can and say, oh, okay, I know about HIPAA. And that's number one, wrong. You should really know this stuff because there are very practical issues that you face even day to day. For instance, I had just privacy in my opioid treatment clinic. We have one patient who is there who has a family member there as well. They are not on good terms and don't know that the other's there, and it is a tough situation, but it's not really tough to navigate the privacy aspects because each of those patients have this siloed relationship with the entity itself. And then, of course, me as the physician and the others involved in their care. It's where you're not going to be like, oh, how's your sister doing? That would be to disclose protected health information, I think, by extension, because you'd be saying at this opioid treatment program, you have a patient who's being treated, therefore, by extension, disclosing that the person has an opioid use disorder. But I would say not everyone gets those what seem to me obvious nuances, or not even really nuances, but the details of HIPAA, or even in broad strokes, it's not really just a computer-based training annual thing that you have to do. It's part of our profession. It's part of the ethics, and it's just codified in law to make things more clear, hopefully.
Yes. So really, again, it's about privacy. What do the patients come to us because they expect us to keep, especially their health information, private. So that's why it is so important to, maybe not everyone can remember every element of the law, but at least, once again, know where to find it, be aware of it, and know what your responsibilities are related to it.
Now, we have a few minutes. Did you guys want to go into any more of this quickly? I don't know. Reading the 8.2 seems like something you'd be familiar with, Kate.
The next question asks, what is the role that congressional authorizing and appropriation committees play in the legislative process? A, authorizing committees establish the operational rules for newly passed statutes and modify operational rules for existing statutes. And appropriation committees decide how much federal funding is allocated for discretionary programs and statutes. B, authorizing committees decide how much federal funding is allocated for discretionary programs and statutes, and appropriation committees establish the operational rules for newly passed statutes and modify operational rules for existing statutes. C, authorizing committees review and modify bills before they are brought to a vote in the Senate or House of Representatives, and appropriation committees decide how much federal funding is allocated for discretionary programs and statutes. Or D, authorizing committees decide how much federal funding is allocated for discretionary programs and statutes, and appropriation committees review and modify bills before they are brought to a vote in the Senate or House of Representatives.
It's kind of definitional, but
yeah.
Something I wouldn't have. I don't think I would have been able to answer this one. They all sound legit.
So let me help, hopefully, everyone to once again distill this down. So I like to think of the authorizing committees as the ones who provide the rules, and the appropriations committees are the ones who are, if you will, providing the funds. So if you just take those two, that piece of information. You look at these choices, and right away you can take out B and D because, as I mentioned, the authorizing committees, they're giving you the rules. And the way these are written, they're talking about authorizing committees providing funding. So right away you take that out. And for C is incorrect because the authorizing committee can only begin its work once a piece of legislation has become law, meaning that it's passed by the House, the Senate, and also signed by the President. That's when it formally becomes a statute. So an authorizing committee wouldn't review or modify a bill before it gets voted upon. So if you look at the timeline and how a bill gets passed, so now you consider it's been passed by both chambers of Congress and also signed by the President. So it becomes law. It becomes what's called legislative law. But now you have to figure out, how are you going to put this into action? How are you going to implement it? That's the operational rule or component, or what's called administrative law. And that's what the authorizing committee does. It helps tell you how, now that we have this law in place, how do we put it into place, or how does it operate? And then once you say, well, this is how it operates, of course, we need funding in order to make it happen. So the Appropriations Committee is the one that provides the federal funding. I do hope that that approach really, helps boil down this language into something that, if you will, is more digestible, but most importantly, memorable to the audience, and gives you a sense of how things work in either in DC or in your local state house, and so on.
Awesome. Well, to the both of you, thank you so much for your time and the work you continue to do, both in education and, I'm sure, in advocacy.
Yes, thank you. And also best to you, Patrick, for this holiday season, and of course to your audience.
Great. Thank you for having us.